Okay, sounds good. Hello, everybody. I am Christopher Baker. I am a pulmonologist in Colorado. You see our institution here in the Rocky Mountains, way off in the distance. Yeah, we're going to talk about bronchopulmonary dysplasia, the chronic lung disease of infancy. And I'm really appreciative to all of you joining on to this virtually. It was obviously unfortunate we didn't get to do this in Philadelphia. But we'll look forward to, I think we're in San Diego next year, and hopefully that gets to happen in person. So I have nothing financial or commercial to disclose, and no conflicts. So the learning objectives for this lecture: to be able to review the pathogenesis of BPD, to summarize the vascular hypothesis of lung development, to differentiate between protective and supportive or chronic ventilation strategies in preterm infants, to recognize the indications for chronic mechanical ventilation in infants with severe BPD, and determine which patients would benefit from chronic ventilatory support, potentially via tracheostomy. Getting to BPD as far as its etiology, so we think of preterm birth interrupting the normal lung growth, and this slide here shows the development of the lung from the early embryonic and pseudoglandular stages of lung growth, where really there's some primitive airways forming and some primitive large vessels in the pulmonary vasculature, but nothing connected. And it's really during this late canalicular stage of lung development where there's finally enough respiratory bronchioles where gas exchange is even possible. And so this whole idea of the margin of viability being around 22 to 24 weeks is based on there not really being any connection between airways and blood supply before then. And, often we think about the preemie baby's little fragile alveoli, but truthfully alveoli aren't really forming until much later. So anyways, at the time when preemies are born, we're really disrupting the development of the lung during the third trimester. So BPD, the chronic lung disease of prematurity, was first described in 1967 by a radiologist named Bill Northway and was associated with mechanical ventilation and oxidative stress. It actually said respirator therapy. They called it the respirator back then. And basically the postnatal injury. And now we see babies born much earlier, 23 to 26 weeks. And so in addition to the postnatal injury, there's this arrested development of the lung vasculature and alveolar structure, which impairs gas exchange. So we have premature birth causing BPD by a lot of mechanisms. So there's hyperoxia and inflammation, infection, and ventilator-induced lung injury, all we think mediated by some forms of oxidative stress. And so this happens to a baby that might have some antenatal risk factors like preeclampsia. Chorioamnionitis, at least in animal models, is a risk factor for preterm or for BPD in preemies, although some clinical studies are kind of divided on whether or not chorio is a strong risk factor. Intrauterine growth restrictions, certainly, fetal infections, and maternal smoking and drug use all have factors. A number of genetic factors have been identified that are promising in some of the larger population gene studies. And nevertheless, that's an area where we could stand to understand some more. All of these serve to disrupt growth factor signaling pathways and lead to impaired alveolarization, decreased vascular structure, and poor lung function. So we'll talk through how that actually plays out in the baby. So the old BPD, we divide this, these terms are a little bit informal, but referring to old BPD and new BPD, the idea was in the era before artificial surfactant was readily available. And that kind of would be described from when BPD was first described in the 60s up until around 1990. And we thought of BPD as being an injury to the lung with a lot of heterogeneous lung disease. You see in this chest radiograph here, marked hyperinflation in some areas and scarring in others, and very heterogeneous. Epithelial lesions, smooth muscle hyperplasia, which in the airways can cause bronchoconstriction and airways disease, as well as fibroproliferation and scarring, some remodeling of the pulmonary arteries, and again, decreased alveolarization, although not on the order of severity as seen with the extremely preterm babies more recently. And these pictures and pathologies from my mentor, Steve Abman. So I don't like giving this talk without talking about the big influence he's had on my career training here in Colorado and for a lot of us in the field of peds pulmonary. But so you could see here with this pathologic specimen, the hyperinflated areas are white and kind of over distended, and then there's scarring in between that almost makes the lungs look like a grape-like instead of the normal lung structure you're used to seeing. So in the new BPD, or the post-surfactant area where survival is much earlier, like I said, we think of this more as arrested development of the lung. There's less commonly fibrosis. Their lung disease is more homogeneous, and you can see here in this film, it's kind of more hazy and diffuse. Rare epithelial lesions, the lung capillaries are much more diminished, and there's a more of a vascular hypoplasia that leads to pulmonary hypertension, not so much from remodeling as much as just decreased vascular cross-sectional area for blood flow from fewer vessels, and then marked alveolar simplification. So this brings us to after the kind of new BPD was described around the year 2000, there was a NICHD, NIH group consensus panel that came up with some diagnostic criteria for BPD. And essentially you're trying to decide who has BPD and then what's the severity. And so the idea was that at 36 weeks age or the time of discharge to home, you'd look at any baby that before that had needed at least 28 days of oxygen. Often it's the first 28 days of life, but could be other than that, needing more than just room air. And then mild BPD would be those babies that were room air by 36 weeks. Moderate would be those who would need oxygen, but less than 30% oxygen, and severe more than 30%. And that should be determined by some sort of oxygen reduction test, because the clinical FiO2 is highly subjective. It depends on physician judgment as far as how stable a baby is. It depends on SpO2 kind of parameters for weaning. And so a reduction test or a physiologic test would be more objective to put the baby in an oxygen hood and reduce the FiO2 and look for stability. That was published later on by Wash et al. In like 2003 to 2005, a few different papers. And then also anybody on positive pressure ventilation or nasal CPAP would have severe. On the right column is just for babies born beyond 32 weeks, and it parallels. And so this group, severe BPD, has really a broad range. By this criteria, all of these babies would have severe BPD. So the first one, a 3-month-old, 26-week female, discharged home on 1/8 of a liter of oxygen. So therefore, the FiO2 being 0.31 on the reduction test meets criteria, goes orally feeding and really more or less stable, kind of the feeder grower baby in the NICU. Or a 3.5-month-old, 24-week baby who's still on CPAP, but just with room air, NG fed, and really they tried to do an oxygen reduction test and was unstable. Or the 4-month-old, 24-week twin boy who had the oscillator extensively early in life and then remained intubated, conventional ventilation, needing a very high oxygen FiO2 of 0.8, and having frequent spells, pulmonary hypertension, and thinking about tracheostomy. All of these babies are severe BPD. So that spectrum is important. And in a more recent group through our BPD Collaborative, a multi-center group that includes 19 different institutions around the United States, as well, or 18 in the US and 1 in Sweden. We distinguish this just a little bit by breaking up severe BPD into type 1 and type 2. It's type 1 meaning CPAP or just oxygen, and type 2 meaning some sort of mechanical ventilation, whether it's non-invasive or invasive. And so then you'll see sometimes be referred to as type 2 severe BPD, means the more severe type. And then there's been a number of studies since then looking at other ways to break it down. Eric Jensen at CHOP published recently testing a bunch of these different definitions and comparing what the outcomes are like later in life, or later on in early childhood, I should say, like the first 2 years of life. This is a nice picture of a baby you could see has a trach, has born extremely prematurely at 24 weeks, and has this heterogeneity that we showed on that very first x-ray, like the quote-unquote old BPD. And so I think it's important to not fool ourselves that old BPD is gone. And in fact, I think the most severe babies now have both. So old BPD meaning the injury to the lung, new BPD meaning the arrested development. So we still see that heterogeneity. We see fibroproliferation and scarring, but we also see simplified lung structure on the alveolar level, and that together really means it's the worst of both worlds. It's kind of on the underlying parenchymal hypoplasia of new BPD, we have the injury of old BPD. So this on the left here is the fibroproliferation on the pathologic level. I've seen the interstitium really thickened and hypercellular. And then over on the right here, we see a more normal alveolar or interstitial structure, but simplification of the alveoli, including a diminishment of what we call secondary septation. So this very long structure here should branch off and create more surface area for gas exchange, and instead it's extremely simplified. So the vascular hypothesis really we'll get to here in a second, but the idea was that they really have marked vascular hypoplasia. So this images here is VEGF staining on the left, and so you see in dark brown in the normal lung, there's a lot of VEGF signal, and in babies with BPD with a thickened interstitium and still cellular, but very little of that dark brown staining for vascular endothelial growth factor. And then another endothelial vascular marker is PCAM, CD31, and you see babies with no lung disease here have Western blots with strong PCAM signaling as compared to babies with BPD. And so the vascular hypothesis is that it's the disruption in vascular growth that leads to impaired alveolarization. Again, this was proposed by my mentor back in the early 2000s. And so neonatal rats have been used to demonstrate this, where angiogenic inhibitors have been used to treat, and shown that by inhibiting angiogenesis, we see not only impairment of the pulmonary vascular growth, but alveolarization as well. And in the same way, pro-angiogenic agents, nitric oxide, VEGF, and animal studies in the rodent models have shown a improvement in a way to treat BPD. Unfortunately, that hasn't translated straight across to the clinical setting, at least not yet. And then I asked the question, can we augment vascular growth to prevent or treat BPD? I think of things like endothelial progenitor cells. I studied those in my lab right after finishing fellowship. One of the fellows attending today, Ben Wisniewski, was my lab research associate at the time, and did a lot of important work on this. So remember his name, Ben Wisniewski. The other cell type, in addition to endothelial cell progenitors, is the mesenchymal stromal cell or mesenchymal stem cell, which there's a promising thought that these cells might be able to augment and prevent or treat BPD as well. We could do a whole talk on the progenitors, but we're going to move on to clinical prevention and treatment of BPD. So when we think about that, the best way to prevent BPD is to not have babies be born prematurely. The degree of prematurity and birth weight are the two biggest risk factors. And so that's nice and great, but unfortunately we can't prevent preterm birth. That would be the best, but it will still happen. So then for babies born early, what do we do? Well, you guys are aware that antenatal steroids like betamethasone are shown to decrease respiratory distress syndrome in the immediate postnatal period. They reduce IVH and mortality. Antenatal steroids have not been shown to decrease BPD incidence, but that's likely due to a marked increase in survival. So more babies are surviving, and thus the incidence of BPD has remained unchanged. And some studies even show that over the decades, the incidence of BPD in our communities has been increasing. It's still a major problem. So exogenous surfactant or artificial surfactant given postnatally, especially during the first hour of life, is important. There are less invasive approaches, like used to be you have to intubate right away in the delivery room to do that. Less invasive approaches would be to intubate put in the surfactant and extubate immediately to CPAP, or to use like a suction catheter or something else with a laryngoscope to deliver the surfactant, or even nebulize it without having to intubate to then use a non-invasive approach. Babies can get multiple doses, has also been shown to be effective. So protective strategies, thinking about CPAP, and like I said, that might involve foregoing surfactant. Protective ventilation using an oscillator or jet ventilation, high frequency, and non-invasive ventilation. Judicious fluid management is important. I'll leave this mostly to the neonatologist, but moderate fluid restriction and kind of being a slight negative balance. Definitely more liberal fluids early in the first 1 to 2 weeks of life has been associated with increased BPD and death. And then caffeine, not just for apnea prematurity, but there's studies showing early caffeine can reduce the risk of BPD. And vitamin A is promising. There's been meta-analyses and multi-center studies which have shown a benefit. It unfortunately requires injections multiple times per week in some of these studies, but I would say caffeine and vitamin A are promising for preventing BPD. As far as treating BPD, the ventilation strategy ends up being quite different for how to treat BPD than how to prevent BPD. So we think of the approach for kind of preventing versus supporting. And so we'll get into that in a few minutes. But really, once we have established BPD, we want to support breathing. And for established disease, we often think of larger tidal volumes given more slowly. And that's kind of with the idea of the heterogeneous lung needing to kind of have a bigger breath given and more time for exhalation with to avoid air trapping. And when's the right time to stop trying to wean and to move towards more supportive ventilation? That's a tough question to answer. Oxygen therapy is unclear. We want to avoid toxicity by overdoing it. That also, we want to avoid effects of retinopathy of prematurity. And optimally, it's not totally clear, maybe the low 90s. There's been a number of studies on this as well. And then diuretics is highly debated. Single doses of diuretics have been shown with numerous studies to improve lung compliance, but their side effects are numerous: osteopenia, nephrocalcinosis, hearing loss, and the long-term benefits unclear. So we do try to avoid not overusing diuretics. There's some centers where neonatologists don't use them, or rarely at all, and others where it's a mainstay of therapy. Still highly debated. So once the baby leaves the NICU, what are respiratory outcomes? And I think these studies are important, but it's also important to remember that as we look at pulmonary function testing in children and young adults with BPD, the history of BPD, that we keep in mind that there's a whole group of patients, the probable severe type 2 patients. Some of those end up improving enough to be able to perform spirometry, but many cannot. And so if they're still trach dependent, non-ambulatory, they're not going to be in these studies. So there's some sort of selection bias here. But looking at outcomes, there's you'll see recurrence of these different effects on lung function. But at 7 to 8 years, BLBW babies in Finland were shown to have a decreased FEV1, and air trapping was more prominent by the RV-TLC ratio. At 9.5 years, a group in Germany looking at those VLBW babies, very low birth weight, with BPD had a decreased FEV1, a decreased FVC, and a forced expiratory flow at 50% lung volume. Then 11 years, being less than 26 weeks with BPD, these babies in the Epicure study in the United Kingdom had a decreased FEV1 and increased bronchoreactivity. So kind of we're looking at this obstructive pattern with the FEV1 being affected prominently. This group from Australia looked at 3 cohorts of babies, all at age 8 years, born at 1991 to 92 as compared to 97, where surfactant was much more commonly used, versus 2005, where we had more kind of modern approaches. And at 8 years later, they showed that the more recent group, the group in 2005, had a much lower incidence of mechanical ventilation in the NICU and more CPAP days, but their lung function at age 8 was unchanged. So the idea that we're getting better at doing this isn't universally true. This is an interesting study from 1990 because it was the cohort of babies described back in the original days in the late 60s, early 70s by Northway. And so looking at age 18 years old of age, normal patients would have 83% had no abnormal spirometry at all. And then getting a methacholine challenge, 17% had some obstruction. Then looking at a matched cohort of premature babies, more of those had a methacholine response. And then when we look at the BPD babies, over half of them, 68%, had either marked reversible obstruction without methacholine or a fixed obstruction that was not responsive to bronchodilator. And then outcomes in young adults. Here's some European data looking at 17-year-olds in the same cohort later on, 8 years later at 25. More asthma, reduced FEV1, 25, reduced lung function more generally, air trapping, a positive methacholine response. And then here, the Australian group again, at age 19, decreased FEV1 and FVC, as well as the ratio, but normal lung volumes. And then at age 25, persistently decreased airflows, but the air trapping went away. So I think over time, it's really been impressive that these investigators have been able to keep these patients involved in their studies this long. And so there wasn't an enormous dropout rate. There's still some, and yet this abnormal lung function persists well into life. And as we continue doing what we do and following these babies, as we go through our careers, we will see studies of older adults, probably even at some point senior adults who were born extremely prematurely, and what effects they have on development of COPD and a long-term late heart disease related to pulmonary vascular hypoplasia early on in life. So if we think about vent strategies as a transition, back to that approach of protective versus supportive. So when we're thinking of protective ventilation early on, we're wanting to avoid lung injury. So sometimes I hear the phrase gentilation, early extubation, really minimal settings, kind of small tidal volume, low or high rate and small tidal volume. So you're trying to get a minute ventilation with, upping the rate and lowering the tidal volume to be less traumatizing to the developing lung. CPAP's another approach, the oscillator, like I mentioned, a delivery room CPAP, minimally invasive surfactant we talked about already. It's similar to the approach for ARDS in children. And then we think of a baby with chronic established lung disease that needs supportive ventilation. So our goal shifts, and it shifts from trying to avoid lung injury at all costs to realizing the lung injury is there, and we want to support the breathing, promote the growth of the baby and the development, have the baby be stable and happy. And so it's appropriate for more established disease where we have that heterogeneous lung like you saw both by X-ray and the pathologic specimens. This approach, like I mentioned, has larger tidal volumes and lower rates, a PEEP necessary to overcome dynamic airway collapse. And then our goal is to support breathing, not hopefully they'll be able to grow and develop enough, stabilize enough to be able to wean or be liberated from the ventilator by age 2 to 3 and be decannulated. But we're talking about months and years, not days and weeks. And this is where we start to think about tracheostomy as an option. So this is a baby where we're doing a bronchoscopy, a supine baby. So in the center view, you see the distal trachea and carina. There's some posterior wall movement, but it's not horrible. The cartilage looks pretty good. And then as we go down into the small airways on the left, you can see left upper lobe totally collapsing. And then the apical takeoff to the right lower lobe here also collapses. And so you can have distal malacia even when the central airways look fine. And we often think of these hyperinflated babies like that maybe they're on too much PEEP and we need to lower the PEEP to reduce FRC and treat that. But in these babies, it can often be the opposite. And it's because of this dynamic airways collapse or malacia that air gets in. And if there's not enough PEEP to stent the airways open during exhalation, we get air trapping that's marked. And so it's pretty striking. Not necessarily surprising after taking care of lots of babies with BPD, but if an ICU doctor is used to caring for, post-op surgical patients or, patients with baseline pretty normal lungs and used to turning down the PEEP to treat the hyperinflation, that seeing to actually go up on PEEP and then you get the next x-ray and the lung volumes are smaller is striking. So ineffective chronic ventilation, this is a figure that describes kind of this low tidal volume, then high rate and short I time ventilation, where you give this smaller breath. And so of course the air is going to go to this area down here where there's high compliance and low resistance. It's going to be very hard to get air into this stiff part where there's, you know, a very stiff, low compliant lung with a lot of resistant airways. And so this is going to lead to worsening distribution of gas, increased dead space, higher PCO2 and FiO2. Atelectasis and overinflation are going to get worse over time. But the larger tidal volume, given with a longer inspiratory time to kind of more slowly and gradually give the breath, can more evenly ventilate. So of course this doesn't happen right away. It's still going to prefer this area down in the base. But over time, we'll work towards improving the distribution, reducing the atelectasis and dead space. And of course, our PCO2 will drop as well as our oxygen requirement. So this is the thinking kind of behind the chronic ventilation strategy. So other factors for chronic ventilation, we want to optimize growth. Of course, babies get lots of steroids with or without evidence postnatally and can end up becoming quite cushingoid and obese. We need them to gain weight, but we mostly want them to gain linear growth, which ties to the lung volume. Are they aspirating? Do they need a gastric fundoplication? That's a whole area of ongoing debate. I would say that over the last 10 to 15 years, our field has transitioned from being quite dogmatically for fundoplication in all patients to protect the lungs to having some more open discussion about who really needs it, and are some babies better off to not have the fundoplication if they're tolerating gastric bolus feeds already and more stable. Airway clearance is huge, suctioning secretions. You think of how just the smallest change in inner diameter of these small airways can dramatically increase resistance, which is proportional to the fourth power of the radius. Then we need to really make sure the airways stay clear. So we encourage bag suctioning with saline, and often the NICUs don't want to do that because of the risk of opening the circuit. Some babies desaturate during bag suctioning or open suctioning, and it's a tricky balance between making sure you're not making the baby worse by an airway clearance therapy versus really trying to promote mobilization of secretions. And probably the most common thing I hear that is where people decide to not use bag suctioning with saline is, well, we were doing that and we weren't, quote unquote, we weren't getting anything out, so we stopped. And I have to remind people that the goal of these treatments is not that you'll put in some saline and suction out a whole bunch of mucus, but that it's like an airway clearance modality, just like VEST or IPV or anything else, where you're trying to mobilize secretions, loosen them, and that if you can do that, the baby can make progress with secretions his or herself, and not so much just purely related to the suctioning. And sometimes we do get a lot out, but that's not the point. And then which meds are indicated, bronchodilators, we talked about diuretics a little bit already, and steroids, a lot to debate about there. And then pulmonary hypertension is its own talk, associated with preterm birth, of course. We do screening echoes, deciding who to cath, who to treat. Those are its own topic. And then for a chronically ventilated patient, I remember emergency management is still primarily about the airway first. Of course, the random person that goes unconscious in the restaurant, you could think circulate, okay, that's important. They probably had a cardiac event. But these babies, anybody with a trach is, think about the airway 5 times before you move on. Agitation and dysynchrony are a problem. Sedation is probably the main technique used. This new NAVA ventilation, neurally adjusted ventilator assist, is a pretty cool form of ventilation where there's an esophageal probe measuring the phrenic diaphragmatic electrical signal, and then from that nervous signal sends that signal to the ventilator. So it really takes away dysynchrony, but appropriate use of this mode of ventilation and how to wean or how to transition is still debated and unknown, and it's really only an ICU modality, so it doesn't help move patients towards going home. And then developmental therapy is, of course, very important. So in an interim summary, respiratory sequelae of BPD persists into young adulthood. Strategies for protective and supportive ventilation differ dramatically. More importantly, the goals of care are very different, avoiding lung injury versus supporting the breathing. And chronic ventilation can give a baby with persistent, severe, that type 2 BPD, a best chance at a positive outcome. So here's a case. This is a NICU consult. They consult pulmonary. So there's a 3-month-old preterm girl, twin, who failed extubation multiple times despite aggressive steroids, dexamethasone, the DART protocols, still having frequent spells. And when you see the baby is in volume control ventilation with a tidal volume of about 5 per kilo, I times 0.4 seconds, the rate's 35, the PEEP is 5, and the pressure support's 12, FiO2 is 50%. Blood gas isn't too bad, 7.3664. And the baby's on Lasix or furosemide, prednisolone every other day, and some albuterol. The X-ray shows hyperinflation and patchiness. Echo doesn't show any pulmonary hypertension, and a flex bronch through the intubated baby through the ET tube shows severe tracheobronchomalacia. So what change in vent strategy would be suggested here? I'll remind you, we were looking at 5 per kilo, kind of smaller side tidal volume, a high rate of 35, PEEP of 5. So change to non-invasive ventilation, increase the tidal volume, I time, and PEEP, and decrease the rate. Increase the tidal volume and the rate, kind of max out minute ventilation. Increase pressure support and decrease the I time, or change to oscillatory ventilation. So DB, are you where you can do this? Okay, there's some, the poll is showing up. So we have 61% of you voted. 16 of you didn't weigh in, but that's okay. I see that the majority of you picked the correct answer, increasing the tidal volume, the I time, and the PEEP, and decreasing the rate. Okay, so if we, DB, do I have control?
Yeah, just
okay.
click, there you go.
And then I still see the poll. Can I close it?
Yep, go ahead and close it on your screen too.
Okay, there we go. So this is the correct answer, B. And so there we go. The child will likely not tolerate extubation from everything we described just then. In severe BPD, a larger tidal volume with a longer I time can optimize the gas distribution, like the slide we showed, and a slower rate can permit adequate exhalation, especially in the context of air trapping. The PEEP to support the dynamic airway collapse that we saw, the malacia from the bronch, and increasing the rate, like if we were to increase the rate and the tidal volume, like that was one of the choices, we might actually get a better blood gas. Like you could lower the PCO2, and sometimes overnight, like, the baby decompensates and like has a little bit of a spell, and people are like, oh, well, the rate's only 14, let's go up. And so we come in the next day and the rate's 26 and the blood gas is better, and the person on overnight, it feels like that was awesome. I just really made a great progress overnight. And we have to remind them that a lower PCO2 is not the goal, but comfortable breathing. And if we make those moves over time, it's going to lead to more VQ mismatch, more heterogeneous ventilation of the lung, and atelectasis, hyperinflation, all of that. And then high frequency, I think of high frequency as the kind of the extreme of the wrong approach. Like if we're talking about small tidal volume, high rate conventional ventilation being inappropriate for established lung disease, then high frequency is like the extreme of that. So really, if a child's acutely ill and a team will decide to put a child with established disease on the oscillator, I get very nervous that that's not going to work. And so often we need to do sedation or kind of double down on the chronic strategy in order to get through a spell, as opposed to thinking about other modalities like the oscillator. Oscillator early makes sense. Later on, it worries me. So then I want to talk a little bit about interdisciplinary programs. We call ours the Ventilator Care Program, but really it could go by other names. Ours really has a history of being formed intimately with the NICU, so it's appropriate to talk about it and to talk about BPD. But so our program's history in Colorado, really it was this collaboration, and I think of Steve Abman, like I mentioned earlier, my mentor, just showing up in the NICU and talking to the neonatologist about the sickest babies, even when he wasn't on service, just having lots of clinical conversations about babies. Jason Gein's a neonatologist here who really helped win over a lot of the neonatal colleagues to the benefits of chronic ventilation. And I think that's a philosophy that we sometimes take for granted now, but 10 to 15 years ago, the idea of trachs for BPD, we'd talk to other institutions and I'd hear sometimes, oh, we don't do trachs for BPD. We kind of think about what do you do, and the issue was either stay in the NICU a lot longer, or say we're sorry, there's nothing more we can do, or wean them to low flow, but they're struggling, they're hypercapnic, they're not stable, and then they're really kind of like a time bomb for a respiratory infection coming back. So our team, like I said, it's really multidisciplinary, both amongst medical teams and amongst all sorts of different providers in the hospital, nurses, RTs, therapists, you name it. So many contributors, and this idea of getting to our pediatric respiratory care unit, basically our pulmonary floor before discharge, that's really to get out of the ICU and focus on educating parents and lining up everything for going home. Clinical rounds, we have two different ones, one in our NICU and one on the floor. And then we have a consult team that's dedicated to the NICU. So pulmonary is trying to be as available to collaborate with the NICU as much as possible. But these kids that stay for chronic ventilation end up having a high mortality, a long length of stay, and a huge traumatic stress to families. So I try not to take that for granted. Sometimes the families might be a little stressed out, be a little cranky. And I think what they've gone through is probably the hardest thing they've ever gone through. And I actually have a couple families where the parents have confessed to me that they were actually diagnosed with PTSD from this. But even without that, I think the traumatic stress is real. So we cover a multi-state region with a whole lot of patients, but I think that's true kind of in a lot of the bigger centers. And a discharge barrier that's really huge around the country and in Canada as well is an inadequate access to in-home private duty nursing. And that's been worse the last few years. There's a paper by Sarah Sabatka from Chicago surveying those of us that do this. And the 96% of the respondents either disagreed or strongly disagreed with the statement, there's an adequate supply of home nursing services in their community. So it's a problem everywhere. This is another figure looking at the many factors that contribute to delayed discharge. So medical factors, of course, are real, stabilizing the baby, but then agency approval, getting equipment, educating the caregivers, and getting the home ready. And really, I'd say the shortage of home nursing ends up being the rate limiting step in a lot of times. Everything else is done and we're just waiting to find nurses. So we standardized our process a few years ago. We used quality improvement, thinking, what works here might not work everywhere. But we did this process map approach, focusing really on care coordination and summarizing everyone's responsibilities. When I started talking about standardized, I offended some parents, so I had to emphasize just because our process for, the process for ordering a ventilator is the same for every single patient, but the overall process is customized for every baby. And then we created a family-friendly roadmap as well. And this led to a huge reduction in our length of stay, 42% overall length of stay, and the after ICU length of stay reduced by 55%. Depressingly, with the nursing shortage, it's almost back up to where it was before. So it's a huge problem currently. This is the process map. We're going to go through every one of these boxes. Just kidding, but there's the citation there from pediatrics. And really, it's all these steps looking towards this dotted line of patient being medically ready to go home, and then all the stuff after that to get out of here. And then this is the family-friendly roadmap where they start in the ICU and come along, they have their trach, they get on a portable ventilator or a home ventilator and they're able to leave the ICU. And then all the things that happen And so our families have these ready to, they're laminated and they go on the wall in the patient rooms so they can kind of check the boxes off. And our education is led by RT and nursing. We do teach back. I emphasize, like, family has to get it. Doesn't matter what you said, they have to get it. Many modalities, handouts, videos, over and over, talking through things. CPR and simulation. We have bilingual materials. Special learning needs like language barriers or dyslexia. We've used things like color-coded med lists or timelines, checklists, really just doing everything we can to help the family get it. In high-fidelity sim, I'm sure all of you at your institutions have some experience with simulation, but really trying to recreate the home environment. We hang this curtain up and have some furniture, and these scenarios involve either the trach being plugged or the malfunctioning ventilator. The families have to go through the actions of saving the baby and then a debriefing process. We don't actually if they're not doing well, we kind of pause and take some steps back rather than let the baby get really, we don't let the mannequin die. And we've done over 100 families. And so we do this kind of close to discharge, trying to get them ready and have it be a confidence builder. It's not a pass-fail test, and it's hard to repeat, but it's there's just limitations to it. But it's we have every family at least do it once. And there's a group from Alabama that described sim as improving caregiver confidence early on, and we published a couple years ago that our families had described the debriefing after sim as the most beneficial part of all of training. And we're now doing this for like patients with just trachs. Rather than having the vent malfunction, we have decannulation and plugging as the two scenarios. So in summary, BPD consists of an interruption in pulmonary vascular and alveolar growth. Preterm infants with severe BPD have features of both new and old BPD. Optimal approaches to preventing and treating BPD remain unclear, and children and young adults with BPD often have airflow obstruction. We saw that from the longitudinal PFT data. Supportive ventilation, chronic lung disease can improve over time. I used to kind of tell families this, and then there's actually some publications from Indianapolis describing this, but it's usually around sometime during when the child is 2 that they can be liberated from the ventilator, and around sometime when the child is 3 where they can get decannulated. I quote those numbers to families, but I say I don't have a crystal ball. Infections and kind of decompensations, clinical surprises happen, and yet on average that's probably true. And I say that we're not going to keep them trached that long for sure. It is an average, but we're thinking years, not, like I said before, not days and weeks, but months to years. And the care of chronically ventilated children is improved with the interdisciplinary program. So should we chronically ventilate infants with chronic lung disease? These are CT scans from Rob Castile at Nationwide, shared with Steve Abbott, who published them. And at age 6 months, you see here the severity of the hyperinflation and scarring in a BPD lung. And then at age 14 months, you still see marked hyperinflation. Look at the diaphragms and scarring, but there's the parenchyma starting to look better. And at 23 months, again, it's like totally flat diaphragm, but we're making dramatic progress here. So this is the progress that ends up clinically correlating to the baby stabilizing. So thanks. This is Sebastian, one of my patients who is doing mini hoops. Awesome game. Probably can't play it very much these days. I wouldn't necessarily want to hang out at Chuck E. Cheese right now, but at some point, mini hoops should come back. Thank you.
All right. Thanks very much, Chris. That's a great talk. Yeah, you guys are busy with all those patients there. Happy to take questions. If you have questions, please put them in the chat. Looks like most people are still logged on. Again, if you have a more complicated question, feel free to ask, unmuted, and we can have you talk. Also, in the chat are links to the registration for next week's seminar, as well as the evaluations for today's seminars. Chris, I guess one question I can ask while you're
sure.
While we're waiting is, I guess what sort of range of PEEPs are you recommending for patients with severe BPD? What are you sending people home with? Do you have floor criteria, you know, what number is too high for the floor?
Yeah, I think that's a great question. And my answer here is not the same as other people's answers elsewhere. So, you know, I would say we kind of fall in the middle as far as compared to other centers. But there are some centers where they have a minimum PEEP or a maximum PEEP criteria for transferring out of intensive care unit. And, you know, something like 10 or 12, and to where they want to see babies stabilized to be on that lower support before doing that. We don't have any limits like that. So I've transitioned kids to the home ventilator that have really severe malacia with PEEPs of kind of 14, 16 is probably my highest where I've sent a child home with a home ventilator. But then I can tell you in Philadelphia at Children's Hospital, they use much higher PEEPs, and they actually have a paper from last year. It's Napolitano from 2019 in pediatric pulmonology. Natalie Napolitano is the first author, but looking at intrinsic PEEP and the idea that if you treat with too low of a PEEP, that the baby's going to intrinsically auto PEEP, generate extra PEEP in order to stent their airways open, and you end up the babies that are really unstable and having trouble syncing with the ventilator, they do much better if you match their, if you try to minimize the additional intrinsic PEEP the baby has to generate with the ventilator. And so then this might not be a baby with a PEEP of 20 sounds super scary, but it's like they're not going to die if they have a PEEP of 10, but they're going to be much more stable in sync with the vent. And so check out that paper. They did measure pressure with a esophageal pressure manometer in a baby that's heavily sedated. And so it's a tricky protocol. It's not just looking at settings on the ventilator, but there's a big variety there. And I think we all stand to learn from that approach. And currently I would say, like, you know, if you made me say a number, I'd say 16, but really there's not a rule at our institution.
Yeah, no, thanks. Yeah, and thanks for pulling in the information about
Sure.
CHOP, and that would be a good paper to look at. I think our guideline is to get to the floor stable on 10, but my fellows on the call could correct me.
And like, you know, we're all learning this. There's also, I would say, you know, at Nationwide, there's like kind of some use of much larger tidal volumes and more sedation. They also have this BPD unit where babies can stay there for well into toddler years. Like they have 2 and 3 year olds. I don't know about how many 3-year-olds, but they definitely have 2-year-olds in their BPD unit. Our NICU starts to get anxious when babies are over a year, but this week we transferred a 17-month-old to our PICU. And then DB, I think in Indianapolis, the NICU babies, when they get their trach, they post-op recover in the PICU. So it's just different the way different centers handle this, but it's not right or wrong as much as systematically where the experience is.
Right. Yeah. And have that interdisciplinary care. So
sure.
All right. Well, it sounds like no questions for Chris today, but thanks again to Chris and Sharon for speaking today, and thanks to everybody who logged on. I think we had over 50 people at one point, and so we'll see everybody next Wednesday.
Great. Thank you, everyone.
Right. Thanks again.